time for the Delaware Valley's first radio doctor.
On call every Saturday afternoon at 5.
This is Your Radio Doctor with Dr. Marianne Ritchie.
Presented exclusively by Independence Blue Cross.
Your health determines your life, your longevity, and your happiness. Let your radio doctor lead the way with your medical education. Your Radio Doctor, Dr. Marianne Ritchie.
Good afternoon and welcome to your Radio Doctor. I'm your host, Dr. Marianne Ritchie. Well, it's February, that time of year when we expect to see respiratory viruses surface, but the U.S. is currently going through a remarkable surge of not one or two, but 4 different viruses. Influenza A, RSV, which is Respiratory Syncytial Virus, COVID, and a GI bug called the Norovirus. Some people have labeled it the Quademic. We're going to talk about that in the second segment. Several months ago, the CDC, Center for Disease Control, reported another outbreak, respiratory infections caused by a bacterium called Mycoplasma pneumoniae, especially in young children. We'll be hearing about all of these contagious diseases, how they're treated, and ways to protect yourself and your family from Dr. John Zurlo, the W. Paul and Ida Havens Professor of Infectious Disease at the Sidney Kimmel Medical College at Thomas Jefferson University. He's also the Chief of the Division of Infectious Disease at Thomas Jefferson University Hospital. Welcome, John.
Thank you for having me.
So, John, let's start with Mycoplasma pneumoniae. That's the Latin terminology for genus species of the bacterium. It's a bacterial infection. The CDC saw this rise begin maybe last spring of 2024 with a peak in August, but it was still pretty high through October. How is that happening? How is it transmitted, I guess?
It's actually a fairly common cause of mostly upper respiratory infections, quite frankly. And it can cause infections in adults, but when we've seen it in children, it's more like adolescents. So I think what's different about this particular sort of outbreak that began actually as early as 2023 is that it's occurred in even younger children, which we don't usually see. It's typically something self-limited, but sometimes it causes pneumonia, and that's what has gotten everyone's attention.
Well, and what's interesting, as you say, it's usually in adolescence, but in my own family, one of our 5-year-old and 3-year-old siblings got it in November. It was pretty scary when I heard that title attached to my grandchildren. I guess the other kind of sneaky thing about it is it has a long incubation. Am I right about that? It can be up to 3 weeks that somebody's carrying it before the symptoms come, and they're spreading the love without realizing they're sick, yes?
Yeah, that is true, that it can kind of hold on and incubate meaning from the time someone is, or in other words, from the time somebody's been infected with it until the time they develop symptoms, can be up to 3 or 4 weeks.
Mm-hmm. And then after somebody has the symptoms, they can still carry it without symptoms, and asymptomatic carriage can last for another set of weeks or months, even if they've been treated. Am I right about that?
Yeah, probably, but we don't have a lot of good data about that, so it's not so clear, really.
Mm-hmm. Mm-hmm. But it is the type of pneumonia. I know I had it in around 1991-ish or so. Nobody else in my family had. I probably got it from being in the hospital, but I wasn't laid up with it. And I guess that's why they call it walking pneumonia. You might have a low fever, a cough, a headache, but it doesn't always present with severe symptoms. But it can progress, can it, to asthma or severe pneumonia, and sometimes even encephalitis? I would think that's a small number.
Yeah, that's very uncommon. Again, happily, it really is a self-limited upper respiratory infection, but when it does really become an invasive disease, most of that is pneumonia. And just as you say, a walking pneumonia, in the sense that people don't get overly sick with it, but they certainly cough, they have fever, and they feel lousy with it, really.
So how do you make the diagnosis of mycoplasma infection or mycoplasma pneumonia?
Well, mycoplasma is a bacteria, and for many types of bacteria, whether found in the bloodstream or in phlegm, we can grow it on plates and culture it and make a diagnosis. Mycoplasma is not so easy to culture in this traditional way. And in fact, it's really in the modern era, in the last decade or two, that we've been able to more accurately identify organisms like Mycoplasma. because we have these molecular techniques where we can take a sample of sputum or even a sample from the back of the throat and look for various kinds of germs that can cause pneumonia or upper respiratory infection, viruses and bacteria. And Mycoplasma is one of those with which we can use these molecular techniques.
So that's good for people to hear, I think, because if it's a simple swab, now a swab is scary for a little child. It's uncomfortable for an adult, but it's better than a needle stick for a little child. And we don't want to be x-raying children if we don't have to, because I would guess if you do a chest x-ray on a little guy, the finding's going to be pretty nonspecific anyway. It's not that there's any clear x-ray picture that's going to say it's Mycoplasma versus some other viral infection, right?
Yeah, that's correct. But I think the reason for the x-ray is, well, somebody comes in, let's say a child comes in with, cold-type symptoms, which include a cough. Now, for the various viruses that are around, that tends to be a self-limited thing. It lasts for, maybe some days, but not too long. I think the people who really come to medical attention are those who just don't get better. They just continue to cough and cough and cough. And that's what would prompt a chest x-ray, either in an adult or a child. And we would find maybe evidence of pneumonia, meaning, some infection actually in the lung tissue, which would then prompt our concern.
And do you think just overall, I guess this sounds pretty obvious, but we were all isolated and separated during the pandemic, and now we're gathering or we're back in school and we're coming back to the workplace. Do you think that's why there's been a bump in all of these viruses? They're reemerging because we were separated for a while?
That probably has some truth to it. I do think that's true. Yeah. We don't have any good evidence for that. But if you look back, for example, about flu, which we'll talk about a little later, there simply was no flu season during the first winter of COVID. That we had almost zero flu, and that almost certainly had to do with the fact that we were not together, we were socially isolated, we were wearing masks to protect ourselves from COVID, but it also ended up protecting us from flu. But maybe, in subsequent years, then we started to see a little bit of the backbiting from that because we weren't exposed the previous year.
Well, it's interesting, too. I was reading from the CDC that the highest increase in Mycoplasma is in children ages 2 to 4. And you figure if they're pandemic babies, they were they hadn't been in daycare. Well, some of them, I guess, were, but that was a big group that hadn't been exposed to anything yet. So that might be part of it, too. And now we're back with not overly crowded, but crowded daycare, school, college dorms, nursing homes, all that. That makes sense. John, how do we treat Mycoplasma? Pretty straightforward.
Well, we have several different antibiotics that are really quite effective in treating it. Commonly used antibiotics that are generally well tolerated. And so you've heard of the Z-Pak, and there are other medications kind of similar that really are quite effective in treating that.
So once it's been identified, and I guess that's why it's important, we're going to talk a little bit more about these viruses that are floating and how we detect which bug is causing the cough, cold, pretty common symptoms to all of these respiratory infections. Because in this case, we do have a tool. We have an antibiotic. And I think a lot of times when people have a virus, either a common cold, and they want an antibiotic, we say to them, we don't want to give you an antibiotic because it's a viral infection. It bumps antibiotic resistance across the country, and you might get side effects that you don't need because you didn't need the drug to begin with. So this term that's being bandied about, Quademic, it represents the idea that we have higher than usual levels of 4 viruses that are occurring in the country right now. And we already mentioned Influenza A, RSV or Respiratory Syncytial Virus, COVID, and the GI bug known as Norovirus. The levels of that have been rising since November. So they're at higher levels than usual, but Quademic is sort of a layperson's nickname for it. It's not really an epidemic of any of these viruses, yes?
Yeah, that's correct. I think, in all honesty, this is really a very typical season in some ways. So we're seeing now in January now leading into February, the rise in one of the types of influenza, Influenza A. So far, we have not seen much Influenza B. That's the second major type of influenza that we see. And sometimes what we'll see is A comes up quickly, and then it drops off. And then later in the season, then we see Influenza B coming along. And then, of course, we have RSV, which is another respiratory type virus. And then the norovirus that you mentioned, really, which causes mostly gastrointestinal illness, vomiting, diarrhea, that kind of thing.
Well, again, I usually start my research by going to the CDC when we're talking about infection. And nationally, it seems as though emergency department visits are very high for flu right now, moderately higher than usual for RSV, or maybe not higher than usual, but moderate for RSV, and sort of low for COVID, at least lower levels than prior winter seasons, because as we've discussed before, herd immunity is the majority of people. I don't know what you would call the majority. 80%, is that the desired effect? Have either been exposed to it or have had COVID or have been vaccinated. All those good things come together to say, step back, COVID. I'm not so bothered by you anymore.
Yeah, well, one of the interesting things also about COVID is that it really never has behaved the way we would have hoped in some way, that these respiratory viruses would peak in the wintertime and drop off in the summertime. Throughout the whole time we've seen COVID, we've seen summer outbreaks. In fact, we're at lower levels now than we were in the fall time with COVID. So it's really not behaving in that way. And it begs our understanding of why that's not the case. And in fact, we don't really exactly know why respiratory viruses peak in the winter. We think it's because people are close to each other, around each other, and makes perfect sense. But why doesn't COVID behave in exactly the same way? And maybe it does have to do with the immunity. I mean, the CDC would estimate something like 98% of the population has some degree of immunity from COVID, either from natural infection, from vaccination, or from both.
Fascinating. Let's take a little break, and when we come back, more about the current circulation of viruses.
Thanks for listening to Your Radio Doctor with Dr. Marianne Ritchie, exclusively presented by Independence Blue Cross. If you have a question for the medical mailbag, just send a note to doctor@yourradiodoctor.net.
And welcome back to Your Radio Doctor. We're so pleased to share the company of Dr. John Zurlo, Chief of Infectious Disease at Thomas Jefferson University Hospital. John, we've talked about this term that's being used in the lay public and the news, quademic. It's not really a quademic, but we're just more aware of RSV, Influenza A, COVID, and the GI bug, which is very nasty, called norovirus. Let's break it down and talk about each one. I thought it was really interesting that you mentioned earlier that in a particular season, fall and winter, in a particular half year, say the 2024-2025, that you may see Influenza A in the fall, and maybe later, February, March, you might see Influenza B rear its ugly head. So people get vaccinated. Let's rewind the tape here. You look at CDC and national health organizations, look at the pattern of flu in South America in their fall and winter, which is below the equator, and they get it before we do. And then what you see there, you predict will come here, and that's how you design the vaccine. Am I right, for this current season? So the ideal time might be October, although this year the flu came a little early, yes? Like September-ish?
No, not really. I mean, we really didn't see, for example, in our area, much of influenza until it really started in December. So it was, I would call it a kind of a typical year. And so, yeah, I think people had been advised appropriately to begin vaccination for influenza as early as September. But I think probably many, if not most people, have gotten it through October, even November.
Mm-hmm. But I guess I was making the point also that you can get the designated vaccine for a particular season, and then if you get the flu later, it could be a different strain of the flu. Yes?
Yeah, there are two issues there. Number one, it could be a strain that's not quite matched. As hard as we try to match the vaccine with what we think is going around, we're not always successful with that. And so as a consequence, even if it's slightly different, the vaccine is slightly different than the circulating strain, then it won't be as protective. And I think the other piece to it is that the immunity that people develop from vaccine is not a very long-lasting immunity. And so in some cases, if people get vaccinated too early, then that immunity might wane if we happen to have a much later, flu season, February, March, even as late as April. So that could be a problem sometimes.
So you have an adult or a child that comes to their primary care doc with cough, maybe some nasal congestion, fever. How do you differentiate among the viruses, and does it matter?
Well, as a general rule, we cannot. The tests that I mentioned earlier in the broadcast, the molecular tests we do, those are not really available at outpatient offices. We would tend to, for people who show up in an emergency department, for example, we would tend to reserve those tests for people who are particularly at risk for severe complications, sometimes young children, sometimes older people with a lot of comorbidities, as we say, other medical problems from which they can get very, very sick from one of these viral infections. So for the most part, we don't know what we're treating unless, for example, the person there has had clear exposure to someone who was already diagnosed with the flu or with RSV. So we kind of have to guess in many cases. And the good thing is, even for things like the flu, RSV, these other viruses, most of those cases end up being self-limited. They go away by themselves, but in some cases, people can get very sick.
When would you use the respiratory panel that you get information from swabbing the back of the nose or throat, or even a nasal wash or a little aspirate?
Yeah, we have a rather simple one, simple in the sense that it's only restricted to a few different viruses. So, for example, at our hospital at Jefferson, we have a sample test that will look for Influenza A, Influenza B, RSV, and COVID. That's all it'll do. And it's not a simple test because it's actually a molecular test. So it can only be done in a facility that has that kind of capability. Then we have a more extended panel that will, look for 12 to 15 different organisms, including Mycoplasma that we talked about earlier, and a variety of other respiratory viruses, which we also see during the winter season.
I know, I'm just going about my grandchildren, that they have some version of the molecular testing in the pediatrician's offices. One of our little guys had RSV, and I always worry that seems to have a nastier form of nasal congestion, and you think these little infants, it's so hard for them to breathe. Are they going to be able to eat and drink enough? So that RSV is nasty. So Influenza A, is that peaking now, would you say?
It absolutely is. It's both peaking. Well, it may already have peaked. I'm a little optimistic.
Hopeful,
looking
yeah.
at the latest CDC data. Looking at our own data from Jefferson, we see that it's perhaps leveled off a little bit with data as early as this week. So Influenza A right now is by far the predominant thing that we're seeing.
And not to get too much into the weeds, you and I like this because, medicine is our lives, but we name strains of Influenza A or Influenza B by the proteins on their surface. People are now aware of spikes, and it's kind of like whatever decorations are on a virus, that's how we identify it. But we name these viruses by H and N, certain proteins on their surfaces. And the ones that are in the 2024-2025 season are H1N1 and H3N2. And what we discussed the other day, you mentioned that we're seeing H5 sneak in. Is that what they call bird flu?
Yeah, that's a cause for careful surveillance, but not a cause for alarm at this moment in time.
No.
This is the bird flu, the so-called H5N1 that people are talking about in the news. That's important. Yeah.
But it's very small numbers scattered through. But I think I only brought it up because if people hear that we're on it, we're watching it, and the surveillance is out there. But you mentioned the other day that the message partly with that, it's maybe seen in wild birds throughout the world, causing some outbreaks in poultry and U.S. dairy cows, but very few human cases. But we want people to avoid drinking raw milk or eating products made with raw milk, yes?
Yeah, that's one of the ways that people can become infected with it. The cases that we've seen so far have been people, again, with raw milk, also with exposure to wild birds, to exposure also to certain farm animals. We hadn't expected, quite frankly, to see bird flu in cattle, but in fact, many of the cases that have now been transmitted to humans have been among farmers who are working with cows and such. So that's
Wow.
a bit unexpected. So it's birds, cows, animals in general, as well as these raw products raw animal products that we're trying to be careful with.
So please stick to pasteurized milk. But there are no current travel restrictions to other countries that have bird flu. And COVID, really, there was a little increase this past fall, but it seems like it's probably more contagious but less virulent than other strains, yes?
Yeah, it's a difficult question to answer, but if we walk through the past of what COVID happened, you remember we had COVID and we had all these Greek letters. There was Delta and then ultimately Omicron, and as we progressed through the pandemic, it appears as though the strains became less virulent. In other words, less likely to cause really severe disease, like we saw in the early part of the pandemic. People would come in and they would die of this overwhelming viral pneumonia, in essence. So as we saw this peak with Omicron in late 21 and early 22, that seemed perhaps to be a little less severe, but at the same time, we had so much of the population that had been vaccinated, and even so, at that time, we had so much of the population that had already been infected with COVID that perhaps that also led to the virus being less troublesome than when it first emerged.
Well, it's interesting too, John, because during the years, initially COVID had everyone terrified and unsettled and nervous and upset. And then as it came to under better control and we were reaching immunity, herd immunity, people would get tested if they had a cold and they say, well, it's not COVID, so how bad can it be? But right now, the flu could be more severe than a case of COVID is what we're saying, that we've built up immunity to COVID. And I'm hearing that some of the little guys that COVID, the 5 and 6 year olds, can have fever for 7 to 9 days. Really nasty.
Yeah, that's true. And remember, just getting back to your point about the flu is not just an upper respiratory infection. There are a lot of common viruses that cause a cold and they get over it, but the flu is different. And we have a lot of deaths every year from standard flu. It's just that's just the way it is. Now, people most susceptible to the severe cases of flu would include the very young and the much older population, but especially adults who have multiple medical problems, especially underlying respiratory problems. So we can't take the flu lightly. We have to take it very, very carefully. It's a very challenging organism or virus because it mutates on a yearly basis, so we have to constantly keep up with it. But it's important we have these flu campaign or flu vaccine campaigns because it is such a deadly virus.
And we don't want people to get away. All right, when COVID came, it was scary. The vaccine hadn't been time tested. It was tested well, and people became frightened by it or cynical. But the flu vaccine is time tested and safe. RSV, similar recommendations. Everybody over age 75, those between ages 60 and 74, if they have a chronic lung disease like COPD or diabetes. Pretty much, is that what we say about the RSV vaccine? And do you only get that once, or do you get that every year?
You're correct in terms of the current recommendations for the age groups. Right now, we think it's just given once. It may turn out that people will need boosters in the future, but right now it's licensed and it's approved for one time only. And at least one of the vaccines that is approved also is for pregnant women late in their pregnancy,
Yes.
to keep them from developing RSV and infecting a very young newborn child. My daughter, for example, is in that late stage of pregnancy, and she's gotten
Oh,
her RSV vaccine. Yeah, right.
well, I wish they had told me because our second child had RSV when she was 5 weeks. It was terrifying to watch her struggle. And then these little guys, too, on top of these viruses, they might get a superimposed mycoplasma pneumonia or pertussis or strep. And again, part of the cynicism or people backing off saying, we're not going to do any vaccines. That's why we saw that rise in pertussis, yes? Was it last year or 2 years ago in Philly with pertussis, whooping cough?
Yeah, I think the challenge is that for people generations past who saw the ravages of these viruses and bacteria on the population, especially young children, quite frankly, they don't know that how bad it can be, and therefore, vaccines sometimes seem like the boogeyman rather than the savior that they truly are.
Let's take a little break, and when we come back, more on the current circulating viruses.
Now, your real champion.
And now for your real champion, I call this segment, Keep Calm and Love a Tow Truck Driver. Dave Torres owns a towing company and often works through the night. He might have to move a car with a dead battery, a car with a flat tire, or maybe one that's parked illegally. But his list of services now includes a different type of pickup and delivery. Just after midnight on January 3rd, Dave was traveling on a dark street in North Philadelphia, 9th and Wyoming to be exact. He noticed a car that was pulled over. Someone stopped briefly and then left. He could see a woman in the car waving for help, so he got down from his tow truck and approached her. What happened next is hard to imagine. He asked the woman if she was all right. She explained that she had just delivered a baby. He was shocked at first and didn't believe her. She was hugging the steering wheel, frozen in pain. He called 911. While he waited for help, he left the phone on speaker so the dispatch operator could give him instructions. Dave lowered the back of her seat so she could lie down. He removed his sweatshirt, then his own T-shirt to wrap the baby on this cold January morning and place the baby on his mother's chest. The operator explained to Dave that he'd need to tie the umbilical cord. He took a shoelace from a sneaker in the back seat. Once he tied the cord, the baby started breathing. Finally, the rescue team arrived and took the mother's, Latasha James, to the hospital with her beautiful new little baby boy. Dave then took the keys to her car, parked it in a private lot where it would be safe until Latasha was discharged from the hospital. Latasha's story began on January 2nd. She had given birth before, so she didn't think the symptoms she noticed through the day represented labor. The baby wasn't due for another month. By 11 p.m., her water broke. She called 911. They wanted to take her to one hospital, but she wanted to go to a different hospital and decided to drive herself. As she felt the baby entering the world, she pulled over and waited for help. 5 different cars stopped, looked, and kept going. When Dave came, she knew he didn't catch on right away, and in plain words, she had to say, "The baby is in my pants." The story continues. It was Dave who picked her up at the hospital to bring her home. Latasha was so happy to bring her new baby Kason home to meet his big brother Carson, who just turned 2 on Valentine's Day. At birth, baby Kason weighed 4 pounds. Now he's thriving at a robust 8 pounds. Latasha can only say, "God bless Dave. He makes me so appreciative. And the next time I see someone who needs help, I'll want to be like Dave." She is forever grateful. As for Dave, he's a dad. In fact, that night he was headed to drop something to his 19-year-old daughter for work the next day. And when he didn't arrive on time, he was getting text messages. "Dad, where are you?" He had to show his family pictures of the rescue vehicles to convince them of the incredible scene that surrounded him. He remembers the joy he felt when his daughter and 2 sons were born, but never thought he'd be acting as the stork. What's remarkable? As a tow truck driver, Dave always helps people in difficult situations. And he's faced a few tough situations in his own life. You see, 2 years ago, Dave returned from a 10-year term in prison. Maybe his dedication to helping others is a reflection of the gratitude he has for his freedom. As a man of faith, a Muslim, he feels very blessed and truly believes that everything happens for a reason. He reflects on those 10 years and says he learned from the experience, which made him a better person. As Dave told his story and philosophy on faith, it was hard to hold back the tears. Dave was the angel who saved a mother and her baby on that cold morning when others turned away. To help a stranger in medical emergency, protect her car, then bring her home from the hospital, that's more than being a good person. It's a magnificent story of redemption. We salute you, Dave Torres and Latasha James. You're real champions. A special thank you to Janice Armstrong, a writer for the Philadelphia Inquirer and the Daily News, who published this story in the Inquirer on January 29th and was kind enough to connect me with Dave and Latasha. Thank you, Janice Armstrong, my new bestie. Welcome back to your Radio Doctor with Dr. John Zurlo, Chief of the Infectious Disease Division at Jefferson University Hospital. John, this is a fascinating discussion about influenza, RSV, which is Respiratory Syncytial Virus, COVID, which is under a little better control now that so many people have the immunity from either being infected or vaccinated or exposed. So let's talk about how the CDC and other governmental agencies monitor these viruses and their activity. Tell us about the National Wastewater Surveillance System. I think that's incredible.
Yeah, that really only sort of took shape in the last few years, where we can actually look at wastewater samples and determine both the presence and even the concentration of various kinds of viruses that give us kind of maybe a heads up that such a virus is now circulating. So, for example, a non-respiratory virus like polio virus, that is constantly looked after in many surveillance countries. And once we start seeing polio virus in the wastewater, that is a very, very early sign that there may be polio around. We're trying to eradicate polio, and that's one way we can have a heads up about it.
And from what I understand right now, levels of Influenza A are the higher, the virus that has higher levels, whereas RSV and COVID are moderate. But we're aware of all of them. But it's just amazing that we're able to do that. Did you say there are other ways to monitor the viruses as well, other than wastewater?
Yeah, many hospitals, including our own, are really our surveillance sites. So, for example, when somebody comes into an emergency department with what we call influenza-like illness, then that becomes a population to study. And for those who get a test to try and find out what's making them sick, one of these molecular tests that I mentioned, specifically flu A, flu B, RSV, COVID, then for people who have these symptoms, they get tested. And if they're positive, then that information gets transmitted as a surveillance thing to the CDC. So at any given time, we can say, this is the number of people who are presenting with respiratory illness, and this percentage of them has flu A, flu B, COVID, or maybe they don't test for any particular virus. And so that's an ongoing, real-time surveillance of what's going on in the community.
One of the little grandchildren, oh my gosh, with my 3 sisters, we have over 30 grandchildren. And one of the little children was sick recently, and he had croup, which we know is the symptoms of the virus, had it, and it was RSV. A few weeks later, had it again, and it was a coronavirus that was not COVID. So as you say, coronavirus has been around for gajillions of years, but the COVID that came to town in 2020 was a different beast. Let's talk a little bit about the norovirus, this GI bug. A neighbor of mine, a senior citizen, but a very healthy one, hospitalized for 8 days with norovirus. I mean, nasty. It's very contagious. How is that passed? I would guess hand washing is a factor.
Yeah, it's passed from person to person, contaminated objects, with saliva, and so forth and so on. It can contaminate foods. So, for example, if foods or crops, for example, are watered with wastewater or any water that happens to have norovirus in it, then that can become contaminated. And the virus has a particular kind of tendency to really last on surfaces. Certain viruses, if they're on a surface, the surface dries out, the virus is no longer viable. But norovirus can really stick around on surfaces, which makes it, really more important to consider things like hand washing, particularly when people in a household have an illness like that, because it is so contagious.
And we were talking earlier about mycoplasma, that a person can be exposed and be infected for 21, 23 days before, and be spreading it before they get symptoms. Whereas with this cootie, with norovirus, the GI bug, you're most contagious when you have the symptoms, and maybe even after your symptoms, after you're feeling better. So with this, you do have the personal responsibility. Okay, I know I'm sick, so I'm going to protect everyone because I know. With other bugs, you don't know that you're spreading it. So wash your hands, please, my friends. We talked earlier about spreading. I would say airports have to be considered super spreaders because now so much is digital. People from around the world come into airports and share their cooties from here and there. And you check in with the kiosk. Think of how many surfaces bugs can live on there. So please wash your hands, especially if people preparing your food, I guess. It's passed from one patient to another if you touch food and share it. And as you say, surfaces that have been sprinkled, either if somebody vomits or stool particles. How about food grown in contaminated water, like oysters or fruits and veggies? Are we at risk from that?
Yeah, in fact, that may be the more common way that people are infected. So that's a challenge. It's obviously hard to prevent, and again, with such a contagious virus, it obviously causes major problems. We see outbreaks. I'm sure many of your listeners know that there are cruise ships that suddenly somebody gets norovirus and then the whole cruise ship gets sick. Now, the good thing about norovirus, for the most part, it'll make you sick. It's not going to kill you. Now, we do see some people who get very sick. They get super dehydrated, particularly people who are older or very young children. They get dehydrated. They don't come to medical attention, and they happily rarely, but they can die from it. For the most part, it's a miserable illness with constant vomiting and diarrhea. And certainly when you planned a vacation on a cruise ship, it's the last thing you want.
Well, we went on a cruise, the whole family, one time many years ago. And about a year later, I remember reading that the norovirus that was passed to maybe 300 people on a sizable ship was from the hot tub water, which makes sense now that you say it because bathing suits and all that good stuff. John, let's talk a little bit more about COVID because you wrote a recent paper. I think people would be fascinated by your work.
Well, the paper actually is not completely finished, but we have all the analysis done. And what we looked at was to try and determine what the virus looked like and how it affected people early in the pandemic compared with a much later time in the pandemic. And in particular, I get a data sheet all the time on a daily basis for all of the cases of COVID that have been hospitalized at our Jefferson hospitals. And what we did was we looked at a large group of individuals early on in the pandemic who were hospitalized with COVID and died during that time. And we compared that to a period much later in the pandemic when people came in with COVID and they died as well. The question we asked was, early on, were they dying of COVID or something else as compared to the latter part of it? Now, again, early on, there was really no immunity from COVID, and we had a lot of deaths in that particular time. So by doing a chart review, a careful evaluation, we found that Yeah, the vast majority of individuals who died early in the pandemic died of that progressive pneumonia and illness that characterized the early part of COVID. But at a much later time in the pandemic, people came in, often they were diagnosed with COVID because we were testing every person who got admitted, but in fact, they were dying of other things. And it just so happened that they have COVID as well. So the reality is, I think it speaks to the fact that, once again, at the early part of COVID, we had a virus that the population had never seen, and it was probably a bit more virulent. And later on, as things went on, when vaccination became very common, when many people that had COVID, then in fact they weren't dying of COVID. But it was since the virus was still around, and since we're testing everybody who came in the hospital, it's not surprising that we would find the virus in many of these people. Now, it really didn't necessarily, it couldn't have done them any good having COVID in that latter part of it.
Exactly.
But it wasn't necessarily clear that that's what they died of. So it was a very different time between those 2 points.
Sure. So say somebody's in a motor vehicle accident and they die from the trauma injuries, and they might be an asymptomatic COVID carrier, but it's tested. And plus the other thing that people forget, the first several months, a whole lot more than I, the testing wasn't as accurate. The results were not as sensitive, meaning the pickup rate wasn't at maybe 25-30% were falsely negative. The person would come up with a negative COVID test, but they really had it. And then with time, our testing became more accurate, more sensitive, more specific, and all those good things. So I guess that plays a role in it too. So the trends since the onset of the pandemic, do you think, as we mentioned earlier, there's been a rise in these viruses because people have become a little complacent about hand washing? I mean, you saw people wearing masks and hand washing and separating. Now, we're groovy. We can go back to our old ways. That has to play a little bit of a role in transmission, don't you think?
Yeah, I do. I do think that's true, especially in a season like this, in the winter months where, we know because we have surveillance that we're seeing flu and RSV and norovirus. We know that to be true, and this is the time to really to be more careful, especially for individuals who could really get sick from these things. Older people, lots of medical problems, or very, very young children.
And aside from lay people or not trusting the COVID vaccine, and then it led to this trend of saying, okay, I'm not going to trust any vaccines anymore. We see this rise. We saw a rise in pertussis, whooping cough last year, the year before. I always remind my patients when they say, oh, my daughter's expecting a new baby, or whatever. I always remind them to get their vaccine updated, the Tdap, that would cover tetanus. You're supposed to get every 10 years anyway, but we don't always think of that. And pertussis. You don't want a grandparent carrying pertussis holding a new 1-week-old baby or 2-week-old baby, yes?
Yeah, that's for certain. Remember, for pertussis in particular, it's the very young child, the infants. They're at risk for serious consequences and serious illness from pertussis. Older people, they get a bad cough. They're not as susceptible to becoming very, very sick with pertussis. We're trying to protect the children.
The baby,
the baby,
because
for
they
sure.
probably had their vaccines when they were younger anyway, the grandparents. But grandparents, please check with your primary care docs and get a Tdap. Tetanus, diphtheria, pertussis. Let's take a little break, and when we come back, a wrap-up with all this good information. And welcome back to our final segment of Your Radio Doctor. We're here with Dr. John Zurlo, Chief of Infectious Disease Division at Jefferson University Hospital. John, if people don't remember anything else, the viruses that we've seen a bump in RSV, Respiratory Syncytial Virus, influenza season, that comes every year, COVID, and norovirus, this creepy norovirus. I mean, I'm a GI doctor. Number 2 is my favorite number, but I don't like people becoming dehydrated from this terrible bug. But as you said, fortunately, norovirus in most people is annoying. It makes you feel awful, but not seeing too many deaths from that, thank goodness. But we can make a big effort in prevention with washing our hands. Don't let the pandemic, now that it's behind us, get you out of the habit of washing your hands, especially you're out shopping at the supermarket, you're holding the handle of the basket, you're touching all kinds of things. Before you pick up a piece of food to put in your mouth, wash your hands. Disinfect surfaces, because you mentioned earlier, norovirus, especially this GI bug, can be on surfaces, and it's resistant to standard household cleaners sometimes. So if somebody in your house has the GI bug, you may need bleach to clean your counters. And I don't know about you, but when I see people wearing masks, I think, okay, but why are you wearing it over your mouth and not your nose? If you're going to go to the trouble to wear it, cover your nose and mouth. So John, let's talk about vaccines. There is a vaccination for flu and RSV and COVID, but not norovirus. But we said that's a friendlier bug. Let's talk about vaccinations.
Well, I think, if you look back at the history of medicine, the one thing that's led to extending life more than any other thing are vaccines, quite frankly. Avocationally, I'm interested in ancient Rome. Now, if you lived in ancient Rome and you lived to be 10 years old, then the chances of you living in your 50s and 60s were excellent. So when we look and say the average age of somebody who lived in ancient Rome was like 35 or 40, but as you can see, almost all of the mortality and the resulting lower life expectancy was because of childhood illness and childhood death. Even as recently as the generation of my parents and grandparents, it was very, very common for them to have children, and the children don't make it out of childhood and they die. My mother had a sister who died of diphtheria in the late 1920s, for example. So the problem is, once again, that we never experience that, our current population. We all experience, a child should not die, and happily, child mortality, both in the United States and the world, is very, very low. And the major reason for that is because vaccines are effective and safe in protecting us from these life-threatening illnesses, these life-threatening infections. So I think people have to keep that in mind, keep that perspective, and think through. Vaccines have been studied. Sure, there are side effects to vaccines, there's no question, but they have been studied, and they are very effective and safe, especially for children.
John, if people wanted to read more about vaccines or these viruses, where would you send them? What website?
Well, as much as the CDC has sort of taken a hit in the public imagination and in the public sphere, the CDC is still a wealth of information, both for the public as well as for for medical professionals. There is up-to-date information for the public. Is written in lay language. So I think the CDC is very good, for example. So there's really a wealth of information. But on the same hand, there's a wealth of misinformation on the internet. And so I think for everyone, for me, for you, for all of our listeners, you have to really carefully consider the source of information that you're receiving.
Absolutely. Well, maybe we should spread the word about your radio doctor and Dr. John Zurlo and get people to listen to this show again. And really, I can't thank you enough, John, because you're a very, very busy doctor and you're the chief of your division. And this is a very busy time for you. And I really appreciate you sharing your time and wisdom with us, because we learned a lot. And I think people will be, a lot of people are helped by your work.
Well, thank you very much. And I enjoyed the time with you.
Thanks for listening to Your Radio Doctor every Saturday afternoon at 5 here on Talk Radio 1210 WPHT. Listen to all of our shows again at your convenience on Odyssey.com, AUDACY.com. Thanks to our exclusive sponsor, Independence Blue Cross, for their continued support. And now, watch every show on YouTube. Just search Your Radio Doctor, and please subscribe to our YouTube channel. It's free, it's easy. Go to YouTube and search Your Radio Doctor, and please click on subscribe. It's free. Our listenership continues to grow, so we invite you to partner in the show as a sponsor. We'll help share your message. Contact me through email. Send a message to info@yourradiodoctor.net. That's info at yourradiodoctor.net. February is Heart Month. We're looking forward to hosting 2 shows here in the theater at the Odyssey Studios at 2400 Market. Join our audience on Tuesday, February 11th. We'll discuss Go Red for Women and women's heart disease, and then focus on heart disease in children and the absolute need for parents, daycare workers, all caregivers to learn CPR for children. So many people need our prayers right now. We witnessed the devastation and loss of loved ones in the helicopter and plane crash this week. Lives, homes, businesses lost in LA and the hurricanes in North Carolina and Florida, and people in your own world who are hurting. Let the worry and suffering of our fellow countrymen be a reminder to us to stay humble. Anyone's life can change in a heartbeat. We continue to pray for peace in our world, peace in our beloved country, peace in our families, and in each of our own hearts. This is your Radio Doctor, Dr. Marianne Ritchie, wishing you a happy, healthy, and safe week, and hopefully a clearer throat with the ones you love, and always here to remind you that your health is your wealth.
Thanks for listening to your Radio Doctor, Dr. Marianne Ritchie, presented exclusively by Independence Blue Cross. To contact Dr. Marianne and to listen to today's show as well as past shows, visit yourradiodoctor.com. This program is paid for by Your Radio Doctor, LLC. All opinions or statements expressed on this program are solely those of Your Radio Doctor and their guests and do not reflect the opinions of WPHT or Odyssey. Today's program has been pre-recorded.